All right, welcome back, everyone. Ready for another deep dive?
Definitely.
Today, we're looking at a potential game changer.
Oh.
Yeah, in how we approach anesthesia in young dogs.
Interesting.
So you know how sometimes we see those clusters of symptoms after withdrawing certain medications?
Yeah, like agitation, even seizures, right?
Exactly. Well, this could be iatrogenic withdrawal syndrome.
IWS.
IWS. And we're going to unpack a 2024 article
Okay.
from the Journal of Veterinary Emergency and Critical Care. It's called
Let me guess.
Seizures in 3 juvenile dogs after intravenous anesthetic drug withdrawal during weaning from mechanical ventilation, suspected to be a sign of iatrogenic withdrawal syndrome.
A mouthful.
Yeah, quite a title. But basically, are we seeing IWS in our patients? That's what we're diving into today.
Makes sense. IWS has been recognized in human medicine.
Right.
But this is one of the first papers suggesting it might be happening in dogs, too.
And that's huge, right?
Yeah.
Especially for vets and owners dealing with pups who've needed prolonged ventilation and anesthesia.
Absolutely. Really important implications.
So let's get into these cases. 3 dogs, all around 3 months old.
Yeah, all young pups.
What even landed them needing ventilation in the first place?
Each one had suspected non-cardiogenic pulmonary edema.
Okay.
So the first case was a Shar-Pei mix,
Yeah.
presented with respiratory distress after, we think, some kind of trauma.
Got it.
Second was a Labrador Retriever, had an apneic episode during agility training.
Oh, wow. Scary.
Yeah. And the third, a French Bulldog, came in with breathing troubles after, get this, a bite wound to the head.
So 3 very different situations,
Yeah.
but all ending up in a similar critical condition.
Yeah, that's right.
And did they need similar meds then for sedation and pain during ventilation?
They did. All 3 got fentanyl, dexmedetomidine, midazolam, and propofol while on the ventilator.
Okay, standard stuff so far. But here's where it gets interesting. What happened when they were weaned off the vent and these meds?
Well, within 24 hours of being extubated,
Okay.
and, this is key, within 10 hours of stopping the midazolam infusions, all 3 had seizures.
Whoa. That timing seems a bit more than coincidence, right? Is that what made the researchers think IWS?
It definitely raises the question. I mean, other things could have contributed.
Like what?
Hypoxemia, electrolyte imbalances,
Sure.
But that time frame really points to IWS. We see this in human kids.
Really?
Yeah. Prolonged use of opioids, benzodiazepines, like midazolam, it's a big risk factor for IWS.
Interesting. The article actually mentions that exceeding a certain dose of midazolam increases the risk of IWS in children.
Right, so exceeding a peak dose of 0.35 milligrams per kilogram per hour or a cumulative dose of 60 milligrams per kilogram increase the risk in kids.
Did these pups receive similar doses then?
2 of them actually went over that peak dose,
Oh.
and all 3 were pretty close to that cumulative dose threshold.
Wow. But there's something else that doesn't quite add up to me.
What's that?
Seizures in all 3 started around, what, 6 or 7 hours after stopping midazolam?
That's right, about 6-7 hours, roughly 5 half-lives of the drug.
So over 97% of it should have been out of their systems by then.
Theoretically, yes.
So why the seizures then? If the drug was mostly gone?
That is the burning question, and it highlights what's so mysterious about IWS. Authors think it's the culprit.
But
Yeah, but the exact mechanism, still unclear.
So what do we know? The article talks about changes in the brain's neurotransmitters. Right?
Exactly. A long-term use of these meds, it seems, can actually change how the brain's neurotransmitters work.
Okay, so we're talking norepinephrine, GABA, all that delicate balance.
Right. And when the drugs are stopped suddenly, these altered systems struggle to readjust. And bam, withdrawal symptoms like seizures.
It's not just about the drug being there or not. It's how the brain's adapted to it.
You got it. And that makes this even harder to manage, wouldn't you say?
Absolutely. And here's the kicker in vet med. We don't have a standardized definition or scoring system for IWS like they do in human medicine.
Really limits our ability to diagnose and treat it effectively.
Exactly. So how do we even approach this if we can't properly identify it? Especially in young animals, their brains are still developing.
You're hitting on a really important point. This study, it highlights the need for more research in vet med.
Big time.
We need to understand IWS better, diagnose it accurately, create solid management protocols.
We're just seeing the tip of the iceberg here. I bet you're itching to walk us through each of those cases, Roll.
Oh, absolutely. Let's start with that Shar-Pei. This little guy, classic signs of respiratory distress, dyspnea, orthopnea, pale gums, and those breath sounds, you know the ones?
Oh, yeah?
Radiographs showed an alveolar pattern in the caudodorsal lung fields. So non-cardiogenic pulmonary edema.
Fluid in the lungs, basically, from the trauma.
Most likely, yes. They give him oxygen, but he kept struggling to breathe. Venous blood gas showed severe respiratory acidosis.
Oh, that's bad.
Yeah, so they had to start airway pressure release mechanical ventilation.
Wow.
And they did an endotracheal wash, too. Sent the fluid for cultures.
To rule out infections.
Exactly. Got to cover all the bases. Now, to manage pain and keep him comfy during ventilation, they started fentanyl, Dexmedetomidine, Midazolam, and propofol infusions.
Pretty standard protocol for a ventilated patient.
Yeah, it is. But here's where things take a turn.
Let's hear it. What happened when they started weaning him?
Okay, so they tried him on CPAP with pressure support before extubating.
Okay.
Slowly stopped Midazolam, then propofol. And they actually upped the Dexmedetomidine during this.
Interesting.
After 5 days on the vent, they fully weaned him, stopped the fentanyl and dexmedetomidine.
And that's when the seizures hit.
Yeah, unfortunately. About 2.5 hours post-extubation and 7.5 hours after stopping all the meds, he had a generalized seizure.
So even after they weaned him completely, seizures still happen.
Exactly. That's where IWS really comes into play. They immediately gave him midazolam, restarted the infusion. A neurology consult was normal, except for some mild ataxia, probably from midazolam. They started weaning him off again, but about 7 hours after that initial dose, another generalized seizure.
So even restarting the midazolam didn't fully stop the seizures from coming back?
Nope.
This is really tricky to manage.
It really is. Shows we need to understand the underlying causes better and have better treatment plans.
Thanks.
But let's keep going with this case.
Okay.
To control the seizures, they started him on a slow phenobarbital load, kept weaning the midazolam. They saw some facial twitching, too, suspected partial seizures, treated those with phenobarbital and levetiracetam.
And that worked?
Not really. They even increased the phenobarbital, but the seizures kept coming back. So they upped the levetiracetam, too.
Still no luck.
Unfortunately, no. The seizures persisted. They had to give more midazolam and restart the infusion.
So they were really fighting to get those seizures under control.
Oh, yeah. They did an MRI, showed some mild, non-specific changes, probably from the seizures.
Yeah.
CSF TAP showed mild mononuclear pleocytosis. But a neuroinfectious disease panel was negative, so they added zonisamide, a third anticonvulsant.
Well, 3.
Yep. And they lowered the phenobarbital. Finally, 6 days after that first seizure, they got him off the midazolam infusion.
Phew, that's a relief.
Right. He was seizure-free for over 20 hours. So they switched him to oral levetiracetam and phenobarbital.
A lot of medication adjustments there.
Definitely.
Sounds like they were walking a tightrope trying to manage the seizures without causing more problems.
Exactly. A very delicate balance.
So after all that, was he stable enough to go home?
He was discharged on phenobarbital, levetiracetam, gabapentin, and cefidoxime.
I bet his family was thrilled to have him back.
Oh, I'm sure they were. And get this, at his recheck a week later, no seizures at home. So they stopped the zonisamide.
That's great.
Right. A month later, they stopped the gabapentin, lowered the levetiracetam. 4 months post-discharge, still no seizures, so more levetiracetam reduction. 8 months out, still seizure-free. They stopped the levetiracetam completely, so just phenobarbital left. Sadly, we lost him to follow-up after that.
Oh, that's always disappointing. But at least he was doing well at his last checkup.
He was. Shows how important careful monitoring and proactive management are in these cases.
Absolutely. Before we dive into the other 2 cases, one thing really stands out to me.
What's that?
Even short periods of anesthesia can lead to IWS. 5 days isn't that long, but it was enough to trigger those withdrawal symptoms.
Really important point, you're right.
So we can't just assume short-term use equals low risk.
Exactly. Gotta be on the lookout for IWS in any patient who's received these medications.
All right, on to case 2, the Labrador Retriever. This active pup had an apneic episode during agility training.
Yeah, he came in with tachycardia, tachypnea, irregular breathing, and was pretty dull mentally.
Poor guy.
He also had non-ambulatory tetraparesis. Venous blood gas showed metabolic acidosis with compensatory respiratory alkalosis and hyperlactatemia.
Whoa, break that down for me. What does that blood gas tell us?
It basically means his body was struggling to maintain a normal acid-base balance, likely due to the initial injury and the respiratory distress.
Okay.
The hyperlactatemia means his tissues weren't getting enough oxygen, causing lactic acid to build up. Metabolic crisis, basically.
And that led them to put him on the ventilator.
Yeah. They also did a thoracic CT scan to see what was going on. Severe diffuse lung consolidation, non-cardiogenic pulmonary edema again.
So, fluid in the lungs. Like the Shar-Pei.
Yeah.
But not directly from trauma this time.
Right. The CT also ruled out a foreign body or any broken bones.
Good news.
Blood work showed panhypoproteinemia, 2 low protein levels in the blood.
So we're seeing some differences in the underlying issues here.
We are. Urinalysis showed minimally concentrated urine and hematuria, suggesting possible kidney involvement.
Oh, that's not good.
Yeah. And they did an endotracheal wash, sent it for cultures too.
Casting a wide net to see what was going on.
Exactly. And like case 1, they used fentanyl, dexmedetomidine, ketamine, midazolam, and propofol for pain and sedation during ventilation.
And they also had to address the low protein and potential kidney problem, right?
Yep. Gave him cryopore plasma and canine albumin transfusions for the protein levels.
Makes sense.
And they provided really comprehensive supportive care. Isotonic crystalloid fluids, potassium chloride, meropitant, metoclopramide, azithromycin, N-acetylcysteine, furosemide, and terbutaline.
Wow, that's a lot.
It was. But they were able to stabilize him. After 6.5 days on the vent, they weaned him successfully.
That's fantastic. But there's more, isn't there?
You know it. Just 15 minutes after weaning, he had a generalized seizure.
15 minutes. That's incredibly fast.
It is. They treated it with midazolam and levetiracetam.
Okay.
This happened 6 hours after stopping the midazolam infusion. Sadly, he had 2 more seizures soon after. Yeah, needed more levetiracetam, and they started phenobarbital.
So even though they got him off the ventilator, seizures still developed shortly after. Another case pointing towards IWS.
Absolutely, and shows how quickly those withdrawal symptoms can appear.
And he developed cortical blindness, too, even after they controlled the seizures.
He did. It's a potential complication of prolonged sedation.
Right.
In all the medical interventions. They sent him home on sulfadoxime, azithromycin, and phenobarbital.
So even with managing the seizures, he was left with a neurological problem. Heartbreaking.
It is, but there's good news.
Tell me there's good news.
He made a full recovery, he got his vision back, no more seizures, weaned off all anticonvulsants, even went back to search and rescue training.
That's incredible.
Right. A thoracic CT 9 months later showed the pulmonary edema was completely gone.
What a roller coaster. From the apneic episode, seizures, blindness, and then full recovery. Amazing.
It was. Really shows the complexity of IWS and how important a multifaceted treatment approach is.
Absolutely. And one thing that really jumps out from this case is how fast those withdrawal symptoms started.
Yeah, just minutes after coming off the vent.
Reinforces how crucial it is to monitor closely during those weaning periods.
Can't let our guard down, even when things seem good.
All right, last one. Case 3. The French bulldog with the bite wound.
This poor guy was in rough shape. Dulmentation, puncture wounds around his right eye, respiratory distress.
Sounds serious.
It was. Blood work showed hyperlactatemia and hypercapnia.
So, like case 2, we're seeing metabolic stress and breathing problems. But this time, it's from the bite and possible infection.
You got it. They stabilized him with IV fluids, sedation, and oxygen. Radiographs showed non-cardiogenic pulmonary edema.
Fluid in the lungs again?
Yep. They were worried about respiratory fatigue, so they anesthetized him, intubated him, and manually ventilated him for transport to a different facility.
So he was in critical condition right from the start.
Well, yeah. At the new facility, they started pressure-regulated volume control mechanical ventilation right away.
Wow.
Venous blood gas showed mixed respiratory and metabolic acidosis.
Yikes.
And the thoracic CT showed marked multilobar alveolar pulmonary consolidation, more non-cardiogenic pulmonary edema.
Same pattern.
Yep. They also found right-sided periorbital trauma, facial swelling and cellulitis, but thankfully no skull fractures.
So fluid in the lungs is a recurring theme here.
Yeah.
But they also had to deal with the bite wound and potential infection.
Exactly. And they used fentanyl, dexmedetomidine, midazolam, and propofol for pain and sedation during ventilation, just like the others.
Okay.
They also gave him norepinephrine sometimes for blood pressure support and frozen plasma for volume replacement.
So the ventilation and sedation management seems consistent across these cases.
It does. And they did all the supportive care, fluids, nutrition, metoclopramide, you name it.
Okay.
On day 2 of ventilation, they put in a temporary tracheostomy.
Interesting. A tracheostomy in this one, but not the others. What was the reason for that?
It made weaning from sedation easier and potentially reduced airway problems.
Makes sense.
And they could suction out any respiratory secretions more easily.
Okay, so how'd the weaning go this time?
After 4 days on the vent, they weaned him successfully. But as they tried to wean him off sedation, lowering the propofol, dexmedetomidine, and fentanyl, he got agitated.
That sounds like an early warning sign for IWS, doesn't it?
It could be. And 8 hours after coming off the vent, he had a generalized seizure.
Oh, no.
Yeah, and another one 2 hours later.
So again, seizures after weaning and stopping meds. That pattern keeps popping up.
Definitely. This case shows how important it is to pay attention to those early signs of withdrawal, like agitation.
Right.
They treated the seizures with midazolam, a loading dose of phenobarbital, and more levetiracetam.
Similar approach to the other cases.
Yeah, they got the seizures under control, and he went home on levetiracetam, phenobarbital, and chloramphenicol.
And no more seizures.
Thankfully, no. He didn't have any at his follow-up appointments, and they were able to lower his meds. But then we lost him to follow-up.
Another one lost to follow-up. Frustrating, but at least he was doing well at his last check.
He was. Shows why client education about follow-up appointments is so important.
Absolutely. Well, those are 3 very interesting cases, each one with its own challenges.
Definitely.
But they all have that common thread of seizures after weaning from ventilation and stopping certain meds, especially midazolam.
You're right. It makes you wonder if IWS is really playing a role here.
Okay, so we've set the stage, explored the cases. Now let's really dig into what we know about IWS, how it might work, what it means for vet, med.
I'm ready for it.
Me too.
Yeah.
This is where it gets really interesting.
You know, it's really fascinating when you think about the nuances of IWS. You see, in human medicine, it's well documented.
Yeah.
Prolonged use of opioids and benzodiazepines.
Right.
They can lead to, tolerance and dependence.
Makes sense.
And that, in turn, can trigger a whole cascade of withdrawal symptoms when you stop those meds suddenly or even just reduce them significantly.
And it sounds like we're seeing the same thing happening in these dog cases, right? Which really highlights how important it is to recognize and address IWS in our world, too.
Exactly. Now, there isn't a universally accepted definition or a scoring system for IWS in animals.
Yeah.
But the clinical signs often line up with what we see in humans.
Like what?
Well, you see things like autonomic dysregulation.
So like heart rate, blood pressure, temperature, all over the place.
Exactly. And then there's CNS excitation, which can show up as agitation, tremors, and in really bad cases, seizures.
Oh, wow.
And we can't forget about the stomach and gut, too. You might see vomiting, diarrhea, that kind of thing.
So it's not just one system, it's a bunch of them. And with a ton of different possible symptoms. Sounds like diagnosing IWS can be a real headache, especially with everything else going on in these really sick patients.
Absolutely. It's tough to tell those withdrawal symptoms apart from other potential causes, especially when you've got a patient with a complex medical history.
Yeah, that makes sense. But the timing of these symptoms, like when they happen in relation to medication changes, seems like a big clue, right? Is that what makes these cases really point to IWS?
Definitely. In these cases, the seizures happen pretty consistently within a specific window after they stopped or lowered certain meds, especially midazolam.
That temporal link, it's pretty hard to ignore.
It is.
And I remember the article mentioning midazolam. It's the benzodiazepine.
Right?
And it works by, enhancing GABA, the inhibitory neurotransmitter in the brain?
That's right.
So if you suddenly stop midazolam, wouldn't that mean less GABA activity?
It could.
And potentially more neuronal excitability, making seizures more likely?
You're spot on. So benzodiazepines like midazolam, they attach to specific spots on GABA receptors.
Okay.
And that boosts GABA's inhibitory effects, which calms the brain down.
Makes sense.
But when you use these drugs for a long time, it can actually change those receptors.
Oh, interesting.
Yeah, like they get downregulated. So when you stop the medication abruptly, the brain's kind of left in this hyper-excitable state.
Whoa.
Less GABA activity and a surge in excitatory neurotransmitters like glutamate.
So it's like a double whammy. That imbalance then shows up as those withdrawal symptoms we talked about, including seizures.
Right. The brain needs time to adjust after being on these medications for a while.
It's like taking the brakes off a speeding car suddenly.
Perfect analogy. The brain isn't being calmed by the benzodiazepine anymore.
Right.
It gets overstimulated, leading to those neurological effects we don't want.
And the article also mentioned opioids, like fentanyl, another drug they used in these cases, can also play a part in IWS. So how do opioids fit into this whole picture?
Well, opioids, like fentanyl, work by attaching to opioid receptors in the brain and spinal cord.
Okay.
They block pain signals and create those feelings of euphoria and sedation.
Right.
But using opioids for a long time can actually change the brain's norepinephrine system.
Norepinephrine, that's involved in arousal and the stress response, right?
Exactly. And when you suddenly stop opioids, there's a big surge in norepinephrine.
Oh, that doesn't sound good.
It can lead to those classic withdrawal symptoms: anxiety, agitation, sweating, muscle aches, and even seizures.
So you've got the benzodiazepine withdrawal making the CNS hyperexcitable, and then the opioid withdrawal comes in and dumps a bunch of norepinephrine on top of it. That's asking for trouble.
It definitely can be. It's this really complex interplay of neurochemical changes, and it can have some serious consequences.
The article mentions some risk factors for IWS in kids, like how long they were on the medication, the total dose, their age, how sick they are, and whether there were any standardized sedation or weaning protocols. Do you think those same things apply to dogs?
Most likely, yeah. We know young animals, their brains are still developing.
Right.
They're especially vulnerable to the effects of drugs, so they might be more likely to have withdrawal problems.
That makes sense.
And being on the medication longer, higher doses, those increase the risk of tolerance and dependence, which sets the stage for IWS.
And how sick the animal is probably plays a role, too.
It does. Critically ill patients often need higher doses of sedatives and pain meds,
Right.
which further increases their risk.
And that lack of standardized weaning protocols, that's a huge issue, too. If we don't have clear guidelines for gradually reducing these meds, we're basically setting these patients up for withdrawal.
Exactly. Human medicine, they've recognized how important structured weaning protocols are, especially in critical care.
So what do?
They slowly taper the doses of sedatives and pain meds over time.
Giving the brain time to adjust.
Right, and that minimizes the risk of those sudden withdrawal symptoms.
It's like getting used to a new environment. If you change things too fast, your body can't keep up.
Perfect analogy. Same goes for the brain and medication withdrawal.
The article mentioned some scoring systems used in human pediatric ICUs to spot and assess IWS, like the Withdrawal Assessment Tool 1 and the Sophie Observation of Withdrawal Symptoms Scale. I think those could be adapted for vet.
That's a great question. Definitely something we need to look into. Adapting those scoring systems for our patients could give us a valuable tool for catching IWS early, allowing us to be proactive and maybe prevent the worst complications.
It would be amazing to have a standard way to assess and monitor these patients, especially those who are at higher risk for IWS.
Agreed. It would make things so much clearer and more consistent. But remember, these scoring systems, they usually look at a whole bunch of signs and symptoms, not just seizures.
Like what?
Things like agitation, tremors, sweating, changes in their vitals, and GI upset.
So it's a whole pattern, not just one thing.
Exactly. And the key is to be watchful, especially during those weaning periods.
Got it.
Even tiny changes in their behavior or vitals could be an early sign of IWS.
We got to put on our detective hats and look for clues.
Precisely. Early recognition is key because it gives us a chance to step in quickly and potentially prevent those really serious complications.
So knowing what we know now, what can we do as veterinary professionals to get better at recognizing and managing IWS in our patients?
Well, first of all, we have to raise awareness of IWS as a potential problem, especially in patients who've been on sedatives and pain meds for a while, particularly opioids and benzodiazepines.
Education is key.
It is. We need to educate ourselves, our colleagues, and our clients about the risks of IWS and how important careful monitoring and gradual warning protocols are.
Right, so no cookie-cutter approach.
Nope. Each patient needs their own plan, and we have to be super careful about record keeping.
Like documenting everything.
Everything. Medication doses, weaning schedules, any clinical signs we see.
That data is crucial, right?
It is. Helps us see patterns and spot potential withdrawal problems. And finally, we need to push for more research in this area.
To figure out better ways to diagnose and treat it.
Exactly. We need validated diagnostic criteria and scoring systems specifically for our veterinary patients.
So it's a multi-pronged approach. Raising awareness, establishing clear guidelines, being meticulous with records, and advocating for more research.
We've got our work cut out for us, but it's exciting to think about how much of an impact we can have on patient care.
Couldn't agree more. Working together, prioritizing this issue, we can make a real difference. Absolutely. Well, on that note, let's go back to those 3 cases and see what specific lessons we can take away, starting with the Shar-Pei mix.
Sounds good. So remember, this little guy came in with breathing problems after a suspected trauma. He needed 5 days on the ventilator and got fentanyl, Dexmedetomidine, Midazolam, and propofol for sedation and pain.
Right, and his first seizure happened about 2.5 hours after coming off the vent, and 7.5 hours after they stopped all the meds. Even though it was a relatively short treatment, he still developed IWS.
Exactly. Shows us that even short durations of therapy can lead to problems.
But we can't assume short-term means low risk.
Nope. We have to be on the lookout for IWS in all patients who've been on these types of meds.
No matter what.
Right. Another thing to remember is that IWS can look different in different patients.
Oh, like some might have seizures, but others might have more subtle signs.
Precisely. We have to be aware of all the potential symptoms, not just seizures.
Makes sense. And this case also shows just how tough it can be to manage IWS once it starts. That poor pup went through so many medication adjustments.
He did. They really had to work to find the right combination to stabilize him.
Amazing dedication from the veterinary team.
For sure. Okay, now let's talk about the Labrador Retriever who had that apneic episode during agility training.
Right. He needed 6.5 days on the ventilator and got fentanyl, dexmedetomidine, ketamine, midazolam, and propofol. And his first seizure was just 15 minutes after weaning.
Crazy fast, right? This case really shows how quickly those withdrawal symptoms can hit.
No time to waste.
Nope. We have to be ready for things to change suddenly, especially with patients who've been on sedatives and pain meds for a long time.
Always be prepared.
Exactly. And don't forget, this case also had cortical blindness after the seizures.
Which really drives home the point that IWS can have serious, lasting neurological effects.
Absolutely. We have to recognize and manage these withdrawal symptoms quickly.
All right, last but not least, the French bulldog with the bite wound. He needed 4 days of mechanical ventilation and got fentanyl, dexmedetomidine, midazolam, and propofol.
And his first seizure was 8 hours after they weaned him from the ventilator.
Right, and this case is interesting because he got agitated when they tried to wean him off the meds.
Yeah, that could have been an early sign of withdrawal, like his brain was struggling to adjust.
Makes you think we should really pay attention to even small behavioral changes during weaning.
Absolutely. Those subtle changes could be a warning sign.
Like a red flag.
Exactly. If we catch them early, we might be able to prevent bigger problems.
Early intervention is key.
It is. So we've got 3 cases here, each with its own challenges.
But they all point to IWS as a possible culprit.
They do. Really makes you wonder if IWS is more common than we realize.
I think so. It's definitely something we need to be more aware of.
Agreed. More research is crucial. We need to understand how to prevent and treat it effectively.
You know, as we've been talking about these cases, and really, the whole idea of IWS, it feels like we're just scratching the surface.
I'd agree with that. These cases, they bring up more questions than answers, really.
Yeah, exactly. So where do we go from here? What are the next steps? How do we learn more about IWS in vet med? What kind of research needs to be done?
Well, there's a lot to unpack, that's for sure.
Right.
The biggest thing is we need to figure out a clear definition of IWS for our patients and some criteria for diagnosing it.
Right, because right now we're just going off what we know from human medicine.
Exactly. We need a framework that's specific to dogs.
So like a scoring system, something like those used in human pediatric ICUs. One that considers all those subtle signs we've been talking about.
Exactly. If we had a validated scoring system, we could figure out a patient's risk, monitor them during weaning, and make better treatment decisions.
That would be huge.
It would. And beyond just diagnostics, we need to really dig into the neurochemical stuff going on with IWS in animals. Like, how are these drugs, especially the opioids and benzodiazepines, how are they messing with neurotransmitter systems in the brain?
So basically, figuring out how the brain gets used to these drugs and why it freaks out when we take them away suddenly.
Exactly. We got to understand those changes to develop better treatments.
The weaning protocols too, right? We need to know the best way to taper these meds.
Absolutely. Age, duration of therapy, severity of illness, all that needs to be factored in.
Evidence-based guidelines would be a huge help.
For sure. And while we're at it,
we
should look into other therapies that might help manage IWS.
Like what?
Things like alpha-2 agonists or gabapentinoids. Could those help ease the transition and reduce withdrawal symptoms? Worth exploring. We need to look at all our options and see what works best.
There's so much we could research in this area.
Absolutely.
It feels like we're about to make some big breakthroughs in how we understand and manage IWS.
I think so too. There's so much to discover.
And it shows how important it is for specialists, researchers, and drug companies to work together.
We need everyone on board to move this research forward.
Teamwork makes the dream work.
Exactly. It's all about helping our patients.
Well said. I'm feeling really optimistic about this.
Me too. I think we're on the right track.
You know, we've been talking a lot about the serious side of IWS.
Right.
But I want to go back to something you said earlier, how important it is to just observe our patients.
Observation is key.
It is.
Yeah.
We're often the first ones to notice when something's off with our patients.
We are. We spend the most time with them.
Exactly. So we need to be vigilant, pay attention, and always question things. If something feels wrong,
Yeah.
trust your gut and look into it.
Couldn't agree more.
That's a good takeaway for our listeners. Pay attention, be proactive, and be your patient's advocate.
Sometimes those little things can make all the difference.
Well, on that note, I think it's time to wrap up this deep dive.
Has been a fascinating discussion.
It has. I've learned a lot.
Me too.
And to our listeners, we hope this has been helpful and sparked your curiosity.
Always be curious.
Remember, every observation, every question, every conversation can make a difference for our animal friends.
And from Vet Nerd Jar, keep those minds inspired, hearts light, and tails wagging.